Welcome dear students. In continuation of special audiometric tests, in this video let us learn about the sixth type of test in this category, that is otoacoustic emissions. Otoacoustic emissions, which is called as OAE in short. OAE is otoacoustic emissions. Now we all know that the sound that is produced in the external environment travels via the external ear, middle ear, finally into the inner ear, and it is perceived in the cochlea, to be precise in the hair cells of cochlea by some electrical changes that occur. But do you know that even cochlea, the hair cells also produce some sounds? Yes, they do produce some low intensity sounds, and this is a feature of the normal cochlea, and this can be measured by us by some very sensitive instruments. A very sensitive microphone is placed in the external auditory canal, and that can pick up the sounds that are produced by these hair cells. And this is the principle of otoacoustic emissions. Otoacoustic emissions are nothing but emissions that are, emissions that are produced by the hair cells of cochlea. So in this test, the low intensity sounds, they're of very low intensity. Okay, the low intensity sounds produced by outer hair cells of cochlea are picked up, and they are measured by a very sensitive microphone that is placed in the external auditory canal. So this test is basically measuring the function of cochlea only, to be precise, not some retrocochlear lesion. Only the cochlear lesions can be picked up by otoacoustic emissions. So the sound that is produced by the outer hair cells travels in reverse direction. That is, first let us see the pathway. First it begins from the outer hair cells, and then where does it go? Into the basilar membrane. From the basilar membrane into the perilymph. Perilymph is the fluid that is flowing in the scala vestibuli and scala tympani. From the perilymph, it strikes the oval window. Oval window where the footplate of stapes is held. From there it travels via the middle ear ossicles, and then it strikes the tympanic membrane, and finally it comes into the external auditory canal where it is picked up by our microphone that we have placed. So this is the reverse pathway of sound, the sound that is produced by the outer hair cells. So when the outer hair cells are healthy and they are actively functioning, otoacoustic emissions are present, and otoacoustic emissions are absent when these cells are either damaged or dead or when they are not functioning. So this is how we measure the function of cochlea. And in all retrocochlear lesions, if there is any problem in the 8th nerve or beyond that, somewhere in the brainstem, the person cannot hear, but otoacoustic emissions are absolutely normal. The outer hair cells of cochlea are functioning and they are producing sounds, and we are able to hear them via the otoacoustic emissions. So OAE is absolutely normal in retrocochlear pathologies. There are two types of otoacoustic emissions broadly. And the first one is spontaneous and next is evoked. Spontaneous otoacoustic emissions are present in a healthy normal hearing person when the hearing loss is not more than 30 decibels. These are spontaneous otoacoustic emissions that are present in a normal, healthy hearing person. These are always present. Next we have evoked otoacoustic emissions. As the name suggests, we elicit these responses, and these are again further divided into two types based on the sound stimulus that is used. The first one is transient evoked OAEs, transient evoked otoacoustic emission, and next is distortion product. Let us see transient first. These are evoked by clicks. A series of click stimuli are presented at 80 to 85 decibels sound, and the response is recorded. So what we are doing in transient evoked OAE, we give a series of sounds in the form of clicks or tone bursts. At what sound range? 80 to 85 decibels. And then we measure the emissions. Next in this category is distortion product OAE. Distortion product otoacoustic emission. In this, what is done is, two tones are presented to both ears. Simultaneously they are presented at a single point of time. Two tones are given. In distortion product OAE, two tones are given simultaneously to both the ears, and this identifies hearing in the range of 1000 to 8000 Hz frequency. The main feature of distortion product is that two tones are given simultaneously to both ears. So these are the two types of otoacoustic emissions. One is spontaneous and one is evoked. In evoked, we ourselves give some sound stimulus and see how the cochlea is responding, and again in reverse direction we measure those cochlea produced sound stimulus. Repeat, cochlea produced sounds. In evoked, we again have transient and distortion products. Now let us see the uses of otoacoustic emissions. This is also an objective test. So as we have studied earlier, it is useful to identify hearing loss in infants, children, uncooperative adults, mentally challenged individuals, and also in malingerers. Any objective test has all these advantages. It's useful to identify hearing loss in malingerers and also any uncooperative adult. It is used to distinguish cochlear versus retrocochlear pathologies. Why? Otoacoustic emissions are distorted only in, repeat, otoacoustic emissions are damaged only in cochlear lesions. In spite of having a retrocochlear pathology, otoacoustic emissions are absolutely normal. So they can be useful in distinguishing both of them. Suppose due to ototoxic drugs or because of some noise induced trauma, let us say the outer hair cells are damaged. In those persons, otoacoustic emissions will be absent. That's how we can identify. And the advantage of otoacoustic emission is, even before pure tone audiometry identifies these lesions, otoacoustic emission can catch hold of this. Next is, with otoacoustic emissions, is that even in 50% of normal people, otoacoustic emissions are absent. Why does this happen? Because if at all there is some middle ear pathology or hearing loss of more than 30 decibels, the reverse transmission of sound does not occur. This does not mean the cochlea is abnormal, but because of some other problem Otoacoustic emissions could be absent, and in some people, even when the entire hearing mechanism is absolutely normal, otoacoustic emissions are still absent. That is the catch with this test. So finally, how can we interpret this test is that if otoacoustic emissions are present, it is a sure shot sign that the cochlea is normal. If they are absent, it could be possible that the patient is normal. It could be possible that he is having conductive type of hearing loss or some middle ear pathology. It could be possible that he is having a hearing loss of more than 30 decibels. It could be possible that his cochlea is abnormal. Any of these is possible if any of this is possible if otoacoustic emissions are absent. But if otoacoustic emissions are present, it's a sure shot sign that cochlea is functioning normally. So please remember that OAEs are absent in 50% of normal individuals also. But still, when this test is used in combination with other tests, I still say that otoacoustic emission is a very useful test. Because say suppose the patient is a sensory neural hearing loss patient and you have done BERA, you have done pure tone audiometry and found out that there is bone conduction, and you have done BERA, you found out some retrocochlear pathology, and you have done a few more other tests also, and now we broadly know whether it is cochlear or retrocochlear. And recruitment test is also done. Recruitment phenomenon is observed in the patient. CC is also observed. And under those circumstances, if OAE is absent, it points out towards a cochlear lesion. If all of them are favoring retrocochlear diagnosis and OAE is absent, then it points out towards a retrocochlear pathology. It is still useful to rule out cochlear disease. If at all OAEs are present, it's a sure shot sign that cochlea is functioning normally. So with this I complete otoacoustic emissions. Basically, they are sounds produced by the outer hair cells which are being measured to identify their function. Next in our list is central auditory tests. Central auditory tests. Patients with central auditory disorders, they have difficulty in understanding speech, more so in noisy surroundings. They can hear that somebody is talking, but they cannot exactly understand what is being spoken. Something like a speech discrimination score. Same concept is used in central auditory tests also. 3 types of speech discrimination tests are used here. I can say it's a specialized form of speech discrimination score. Speech discrimination tests are done. If the speech discrimination score is poor, we say it is sensory neural type of hearing loss. But in sensory neural also, to identify where exactly is the problem, we have 3 specialized type of tests. One is monotic test. What is monotic test? The patient is given some speech message not in a very clear fashion, in some noisy surroundings, or the speech is not clearly spoken. Now some people do not speak clearly, they mumble or murmur and their speech is not clear. So such type of speech is given to the patient, and a patient with lesion of the brain, that is in the cortex, will have difficulty in understanding this message. Normal people also have difficulty in understanding a speech that is not clear, but these people absolutely fail to understand. So that is monotic test, wherein a distorted speech is given to the patient, and if they fail to understand, it points out, I am not saying it is diagnostic, but it indicates that probably there could be a lesion in the cortex. Lesion in the cortex of the brain. Next in this category is dichotic test. After monotic, it is dichotic test. In dichotic test, two different speech messages are presented simultaneously. What happens in our normal life? We are sitting in a room and two people are parallelly speaking to us. Normal people can hear both of them, but a patient with central auditory defect cannot hear both these speeches if they are simultaneously presented to both. You should ask the patient to identify both of them. And while performing this test, general questions like what is your name, how are you are not asked. We use specific spondaic words. Spondy words are used. That is 2-syllable words with equal stress on each syllable. Those words are used with some numericals in between, and some nonsense words are also kept. Basically, the intelligence of the patient should not help the patient to participate in this test. Absolutely, they should be able to repeat what they are hearing without any guessing activity. So we do it in such fashion. Basically, what is done in dichotic test? Two simultaneous speeches are given to each ear. Now, what does this indicate if the patient fails to interpret this? It indicates a temporal lobe lesion of opposite side. This is important. Temporal lobe lesion on the contralateral side. That is, out of both the speeches, the patient fails to hear the right side speech. That means there is some lesion in his left temporal lobe because the fibers are crossing. This is dichotic test. Next we have binaural test. Binaural test sees if the patient is able to, if the patient is able to integrate the information from both the ears. When do we use this? How do we identify the direction of sound? Because both the ears are functioning, we can identify from which direction the sound is coming. So both the ears will integrate the difference in sound levels and many other such things and identify. So these tests are normal in cortical lesions, but they are affected in lesions of the brainstem. Binaural tests are used to identify integration of information from both the ears. Now, both the ears are simultaneously hearing so many sounds and they should be able to integrate the sound, just like how our eyes work together. Similarly, ears also must integrate the information, although it is not as complex a pathway as vision, but still even auditory pathway, both the ears have to integrate that information and function as a single unit. And binaural test tests that particular function. So this is to identify integration of information from both ears. Integration of information from both ears. And in whom is this affected? When there are lesions in brainstem, because that is where crossing occurs and all these functions occur. If there is some lesion in the cortex, this test is not affected. Integration is not affected when there is lesion in the auditory cortex. Brainstem lesions will cause a problem in this activity. So this can help to localize the site of lesion. So this is binaural test. So in central auditory test, we are performing speech discrimination tests such as monotic test, dichotic test and binaural test. And these are used to identify lesions at various levels. So if we observe the entire spectrum of assessment of hearing, our first criteria was to differentiate between conductive hearing loss and sensory neural hearing loss by all the tuning fork tests, and up to pure tone audiometry also, that was our focus. Is it conductive or is it sensory neural? And then slowly we moved on from sensory neural. What type of sensory neural is it? Is it cochlear or retrocochlear? All these special tests and even impedance audiometry, acoustic reflex, tympanometry, all of them help to identify between cochlear and retrocochlear lesions. All the special tests are also for that purpose. And in retrocochlear lesions also, is it in the 8th nerve or beyond, somewhere in the pathway, brainstem or the auditory cortex? Those can be identified by the central auditory tests. Not just central auditory, even electrocochleography, BERA, they all also give an idea if there is some problem in the 8th nerve. And central auditory test will finally identify if there is a problem in the cortex or in the temporal lobe itself. Central auditory tests are not very popular because they are affected by so many factors, and if at all the person is having some brainstem lesion, it is not just his hearing that is affected. There are so many problems all through, and hearing is just one of the parameters that is checked in such a patient. Now that becomes a neurological case, and so many tests are done to identify the lesion, and hearing is one such parameter. Per se, in a hearing loss patient, we generally do not do central auditory tests, but they can be done at the end stage to give us a clue about where the lesion is present. So this is about all the special tests, and we also complete the entire assessment of hearing topic, which is one of the most important tasks to be done in the department of ENT. Because the primary complaint, because the most common complaint the patient comes to us, and the most important complaint is hearing loss. And when a patient comes with hearing loss, we must assess the hearing loss, and for that we apply all these tests and examinations, and finally we come to a diagnosis of where is the lesion by all these tests. Thank you very much.